about the phaco difficulties intraoperative during phacoemulsification. So we have very highly experienced and eminent phacosurgeons, not only in India but also in Egypt. So we have Dr. Rakesh Shakia from India, and of course you know that Professor Dr. Yahya Salah, the very famous phaco surgeon and anterior segment surgeon in Egypt, and the master of phacoemulsification in the Middle East, Dr. Khalid Abdelrahman, and myself, Ahmed Mostafa. So the agenda will start as follows. We'll start with Dr. Rakesh Shakia, who will talk about the errant capsular axis. So please, Dr. Rakesh.
Thank you so much. And first I would like to thank Egyptian Society, and especially Dr. Ahmed and Dr. Gahri to inviting me as such a young doctor. I'm talking about the errant axis. So the continuous curvilinear capsular axis is the acceptable standard method of the anterior capsulotomy in the cataract surgery. So as you all know, what are the criteria of the ideal capsular axis? So initially, first nick is nick, and it should be central, circular in size, and it's the continuous, and it is actually covering the aisle optic 360 degree. It's the criteria of continuous curvilinear capsular axis. If there is any of these steps become slightly mismatched, it means there is the affect the outcome of surgery. Then after that you can easily remove the cataract, and so the phaco maneuver become very easy when the axis is very circular in size. So it is you can see it. So as you all know, there are the two forces during the capsular axis, the shearing force and traction force. So I think the traction force is more important to get the axis on the track when it is turned errant. So there are the many factors like shallow AC, weak zonules, high positive vitreous pressure, and intermittent hypermature cataract or pediatric cataract, small pupil, and when the performing the last CC and novice surgeon attempting the CCC, and uncooperative patient, poor anesthetic. So the radial tears actually during the CCC is one of the most unwanted event, and the surgeon may experience that during the cataract surgery. If the axis just go up to the equator, it can be retried. But when the tear go just anterior capsular axis go posteriorly, you can see the anti-lens tear, and you can see the non-fluttering is, and the posterior extension of the axis note the inward turning of the is. You can see in this this animated video. So the posterior extension, this is the free floating margin is becomes slightly inwards. So this is the latest trick when the axis run out or become errant. So I saw the videos. When the axis go slightly run out just a quarter, it can be retried. So first you put the visco just in front of the this capsular track, and put the visco very in front, and just keep it in flat. So the axis lie in the flat in the same direction, and then hold the capsular track near to the base as possible, and just first you just stretch the backward and horizontal direction, and then second to pull the axis toward the more centrally, and it will come into the track. And after that you can make a circular axis, but it is slightly not circular, but is oval, but the margin is the continuous. So after that you can see when you retract the iris, and if the margin is continuous, you can do the phaco in the normal parameters, not need any adjustment. And then keep the aisle in the back, so the aisle haptic should be perpendicular to this extension. This is the second case, when the axis is not retrieved. Sometimes actually this little text not actually work in this type of cases when the interlenticular pressure is high. It is not come out. So the avoiding the blinding stitching. Blind stitching should be avoided. And it is also avoided when some surgeon is cut with the Barnes seizure near to the extension. This is, it should be avoided. So for this, I always actually follow the inverted T technique. When the axis is not retrieved. Like when the axis go in the one side, like that, due to the high lenticular pressure, it is not retrieved. So you can make another nick just parallel to the limbus, and then put the EGSCOE, and with the help of Barnes seizure, you cut in the center, and then after put the EGSCOE, lift the flap, and then complete the axis in the both semicircles. It should be completed in the outside in direction. Another case is when the axis just want to go errant. So you hop after putting the EGSCOE, and then just hold the near to the main port, not on the in the tear side. So you can easily complete it. And every time you put the EGSCOE, and flaps should be directed toward the center. If the axis actually go errant become on the both sides, so it is the Argentinian flag sign. So it's the simple technique. First, if the row go the radial, so immediately stop from the axis and fill the antechamber with the high molecular weight viscoelastics, and make sure nothing pressing the on the globe like finger speculum or like lid sketching, and remove the some of the cortex by the dry aspiration with the help of visco cannula, and then with the help of Barnes seizure we can complete the both semicircles, and so the beginner we can do very easily. And during the phacoemulsification actually, so avoid the perpendicular force against the capsular tear, and nuclear divide with a very soft vertical chop or sculpting or supra capsular phaco with the low parameters. And after removal of the cortex, I'll implant it and keep the haptic perpendicular to the tear. And after that we can make a slightly semicircle, slightly circular, so the rotation is become very less. And you can, the second question, how to avoid it. So first you puncture and the liquefied cortex, aspirate the liquefied cortex, use the high molecular weight viscoelastic. So I always use this technique, just aspirate and then put the EGSCOE over it and make a small axis first. It should be about 3 mm or 4 mm after aspiration of the cortex, and then make another axis in the same way. So this is the secondary axis. And do the phaco very easily. Sometimes the lens capsule become as a calcified. So it always use the cystitome. You make a just a nick with the help of cystitome and the parallel to the limbus, and just with the help of the Uttara forceps or micro-axis forceps you can complete it. But near to the main port, sometimes the axis flap is come out, sliding come out, so it become errant. So put the EGSCOE and hold the whole, actually the hard part, and then put the traction force toward the center. So you can easily make it slightly circular. If there is no, if there is not retrap, so you can use the bonus seizure also to cut it and complete it. This is the case of the microcornea small pupil. The lens was very hypermature, and so put the pupil expander, and after nicking, the and fluids come out. Sometimes the antechamber become turbid. But near the fibrosis, actually, the capsular tag does not come to the center. So just put the visco and flat the margin. Sometimes the flap is also come out, but it's the direction of the, not direction of the extension, and then it's completed. So the same little tricks can be applied in the posterior capsular rent also. Just flat the, sometimes it also come towards the anterior side. So you can just peel off an antibitectomy done, and then put the oil in the sulcus and optic capture done. Sometimes due to the BTS tag, it is not properly, you can't do the posterior capsular axis. Like that, it is sometimes the BTS is prolapse. So you can do the vitrectomy and make it circular, and implant the oil in the bag easily, because the tear was very small, so it is circular, so you can implant the bag easily. This is the high frequency capsulomy. I actually don't have any experience. There are many other modality like the laser assisted or Japto rexis are available. That you can precise the rexis, but it is not available in everywhere. So the mostly surgeons rely on the manually. So this is the line at the axis of the heat convert the coil into diamonds. Likewise, hard times convert the good phacosurgeon. Thank you very much.
Thank you very much, Dr. Shakya. I will keep the question until the end of the presentation. So please, Dr. Yahya Salah will talk about when the soft cataract turns hard.
Thank you, Dr. Ahmed. Thank you, Dr. Ahmed Mostafa, for organizing this meeting. I'm going to explain and show how we can have the soft cataract as a cataract for beginning. First, we just should know this, because soft cataract does not only include pediatric cataracts, but also includes a really wide range of the patients that we see in our practice, and particularly junior staff sees. Whether it's nuclear cataract up to this grading until nuclear grade 3, or cortical cataract up to grade 3 or 4, C3 or 4, and posterior subcapsular cataract. So there is a wide range that we have to know how to deal with this. The idea of that we have always said when training for phaco, juniors or beginners should not do phaco. This because of the few reasons. One, you should master the foot switch and the fluidics of the machine. It is much more difficult to do the regular fracturing techniques that you have learned, and also it's easier to pass through the nucleus to open the posterior capsule, which is really something that frightens any beginner surgeon. But actually, if we follow what I'm going to share with you now, actually this should be cases that we should start with during phacoemulsification for beginners. The main thing is a proper capsulorhexis. A continuous capsulorhexis will help you to be able to do what is extremely important or the key of converting the hard soft cataract into a cataract that beginners can start with. This is in slow motion. I will show the main essence of dealing with any soft cataract is hydrodissection, hydrodelineation, and hydration. And to understand hydrodissection, we have to see and understand what we expect, what is the end point of hydrodissection. So you go with the cannula under the anterior capsule to the equator. After checking the power, you are injecting with the fluid, and you have to see this wave, and you have to make sure that with pressure and displacement of the nucleus, you will make sure that the fluid will pass. This is the key element in hydrodissection. If you understand this, you don't need even to rotate the nucleus, and you will understand if you have done proper hydrodissection or not. And then you can do hydrodelineation in less soft lenses. And then you will learn to do hydration, but the start is hydrodissection. So I will share with you so many different examples just to stress the point that to deal with the wide range of soft cataracts, it is not only pediatric cataracts, that you have to learn to do proper capsulorhexis, and you have to learn to do proper hydrodissection, which is followed by delineation and then hydration. The more you add hydration, it means it's a softer lens. So, and then you will see how you are going to deal with it. You see, this is hydrodissection, hydration. You cannot do proper hydrodissection without proper capsulorhexis. You cannot do proper hydrodissection and hydrodelineation without understanding how the fluid should move behind the whole nucleus, whether it is soft or a harder lens. Once you are able to hydrate the contents, whether the nucleus, if there is a nucleus, prolapses, or whether the whole contents of the bag prolapses just from the anterior chamber, then the difficult case is turned into a simpler case. All you need to do is to use the phaco handpiece as a perfect irrigation aspiration tool. And what you need to do as a beginner or a beginner phacosurgeon is then to experience what you have learned, how to use the foot switch, to understand the sound and the correlation of the sound of the machine with the parameters you have preset to do proper irrigation aspiration. This is a pediatric cataract, and again, it is the proper capsulorhexis. The essence of this is proper capsulorhexis, and here you can see you can hydrate, giving time to fluid to pass through the behind the nucleus into the nucleus and prolapse everything into the anterior chamber or between the capsular bag and the anterior chamber. This is simply you are going to aspirate in a very controlled way, even single-handed, the whole contents of the bag. If you try with this nucleus to fracture it in a regular way, you will not be able, you will pass through it. So the other hand here is just manipulating the globe and feeding the cortex or the nuclear material, which is here is very soft, to the phaco-tip, which is behaving as an excellent irrigation aspiration handpiece. So to sum it up here, I will show you different examples with different grades of capsule, different grades of nuclear hardness that goes under the title of soft cataract. As we have I've shown in the early slide, with the classification, locus classification, you can see there is a wide range of cases that you are going to meet as a phacosurgeon that could be put under the title soft cataract. So, look at the parameters. Here you can see this is the foot pedal, the position, the height. This is the height of the bottle, the vacuum, and look the power used. If you use in such cases more power than needed, if you are not able to do proper hydrodissection and hydration of the whole nucleus, it would never flip like this. You will never be able to cut it and feed it into the phacotip. So power here is almost nothing. You can see on these three gauges, the main working thing is the vacuum. It is phacoaspiration truly, and is helped by having a proper capsular access and proper hydrodissection, proper hydrogenation and hydration of the nucleus. The softer the nucleus is, the more hydration you need to do to be able to aspirate as an amalgam. The less soft it is, but still in the category of soft cataract, that you will need to use the other hand, the chopper, the Seniski, the iris reposter. You will need to be careful to do proper hydration and hydrodelineation to be able to fit it into the phaco tip. You can see here you debulk, you aspirate, you can end up with a crater, which is difficult to deal, and this is a common mistake that beginners will do. But to overcome this, you can shell it out a little bit, and then with the proper hydrodissection, you can flip it all over. And this necessitates proper use of the foot switch. يعني زي ما كأن واحد بيسوق عربية في الزحمة، أنت تقدر تزود السرعة وتقلل السرعة، البنزين والفرامل according للكنترول والزحمة اللي قدامك عشان ما تعملش حادثة. So here you can see you can bypass the problem that you have a crater to start to flip this shell into the phaco tip. And you can see again that it is the vacuum which is controlling everything, and the movement of your hand, and you have to be extremely careful to avoid this situation. That's why hydration of the contents, prolapsing it through the capsule will facilitate removal of the whole nucleus through the phacoaspiration without risking the posterior capsule and needing much more experience. I'm showing that this is a repeatable maneuver. You should learn to do it every time you tend to do a soft cataract. Here it's a complete amalgam. Much easier than the previous case because here I gave time for hydration, so I risk less, I need less experience actually here. That's why this is the best technique for a beginner to do soft cataract. All what you need to learn is to use the foot switch properly and to do irrigation aspiration. Hydrodissection, learning that the wave has to pass. You are not just injecting without understanding what you expect as an end result of your injection. You inject to make sure the wave of injection passes behind the whole nucleus and making sure that it passes to the other side. Then you are sure you did proper hydrodissection. Then you can hydrate the contents, and in this way, using the vacuum, you can avoid all the difficulties that might anticipate you dealing with the soft cataract. And the left hand here, Actually, you are not chopping. You can use any instrument. If you are beginner and afraid to use a chopper, if it is sharp, you can use a Senesky hook. You can even use an iris repositor, fine iris repositor, to just feed this cortical amalgam into the tip. And be careful not to go out with the irrigation ports through the incision, otherwise you will have a collapse of the anterior chamber. And we are using here you can see high vacuum that can reach to 450 millimeters of mercury. The key, proper capsulorhexis, proper hydrodissection, proper hydration, that will allow you to end safely removing all the contents of the bag and be able to implant the lens even if you are a beginner. It's a concept that you should learn to get much better results in such cases. Thank you for your attention.
Thank you very much. Now we'll shift to the opposite extreme of the cataract, the hard rock cataract, and we have now the Dr. Khaled Abdelrahman will talk about how to smash hard cataract. I do believe that sometimes that soft cataract may be more challenging than the hard cataract, and Dr. Yahya Salah showed us how we can manage such soft cataract very efficiently. And we'll keep the questions until the end of the presentation, so we have plenty of time for discussion. Thank you. Dr. Khaled.
Thank you, everybody. Title of the presentation is Erased When We Converted from Keynote to PowerPoint. First of all, I would like to thank Dr. Ahmed for the very nice meeting, and I would like to thank Asaf for the nice introduction of myself. First of all, we all know that it's time to change from ECC in hard cataract to phacoemulsification. But really, hard cataract is a real challenge during the operation, and we have to consider many points to be able to get rid of this case. And most important that I'm aware about that I have two things I have to take care about. First of all is the corneal endothelium. I have to take care more to the corneal endothelium, even to the posterior capsule. But all of the surgeons is taking more attention to the posterior capsule than the endothelium, and the end result, the patient needs another surgery in the future. The point is capsulorhexis, and of course the news of the patient is liable to more stress during the phaco procedure, and I'll tell you how to avoid this stress. And third is the corneal endothelium. As I mentioned, the nucleus division is challenging in most of the cases, and the posterior capsule of course is liable to rupture during the surgery. First, regarding the capsulorhexis, I have first to tell that we have the soft shell technique. Soft shell technique, first we inject the dispersive OVD, mostly is the viscote, and to push the cohesive beneath or under the dispersive to push it into the endothelium of the cornea. But I like to draw your attention that if you are using methyl cellulose, the shape of the capsule will be convex like that, and it is liable to escape in most of the times unless you have to inject methyl more and more during the capsulorhexis. Regarding the viscote, the surface of the capsule will be flat, and you will adjust the size of the rhexis more and more, and the viscote will be retained inside the anterior chamber, and it will not go outside very easily like the methyl cellulose, because it will be retained inside the anterior chamber and keeping the anterior capsule flat like that. The sodium hyaluronate, whenever you increase the concentration of the sodium hyaluronate, you increase the concavity of the anterior capsule, so that the rhexis will be more and more smaller in size. The dispersive OVD, I use dispersive OVD in all of the cases. I don't use any cohesive OVD in the step of the capsular axis. And as you see here in the intumescent or hypermature cataract, first I'm going to puncture the anterior capsule at the center, aspirating all the liquefied material from underneath the anterior capsule, then starting to do the capsular axis as usual. First, sometimes orange peeling, sometimes you can master the size of the axis from the start according to the amount of the liquefied material aspirated from the undersurface of the anterior capsule. Here, I think this case will be orange peeling. Time you have to do your axis step by step. Don't be in hurry. Don't catch only 3 times or 4 times, but you have to catch the capsular axis many times to be able to adjust and to avoid any escape and long flap, because long flaps means escaping of the anterior capsule into the equator, as we saw with Dr. Rakesh in the first presentation. Finally, you are adjusting your capsular axis according to the size and centration. Sometimes in black cataract, I have to stain the capsule and to fashion the capsular axis. As you see, the capsule and the flap should be lying flat over the surface, no ribbing motion, otherwise you may have distorted capsular axis or enlarging the capsular axis without any desire for that. Sometimes I'm relying on the difference in luster between the capsule and the cataract. Here there is no staining of the capsule, but you will feel that there is difference in luster between the capsule and the underneath cortex. As you see, the capsule is shining while the underneath cortex is, or the cataract is dull, so that you can identify where is the edge of the capsular axis and to continue the capsular axis according to the desired size and centration. Then, what about sculpting? Sculpting is the main reason and the difficult, I think this is the most difficult part in cataracta nigra and hard cataract, because we are affecting the subincisional zonules if you are pushing the nucleus too much. First, I have to hold the nucleus by putting the tuber at the equator of the nucleus under the anterior capsule. By this, I can fashion the sculpting very fast without any hazard over the subincisional zonules, because most of time, while we are doing the sculpting, we are pushing the nucleus many times in the opposite direction, so that at this moment you are in a problem because the subincisional zonules will be weak. Then splitting the nucleus in very hard cataract like that, I don't like to do hydrodissection, because I don't know if there is posterior polar cataract or not, so that I am waiting up to splitting the first split to see the posterior part of the nucleus and the posterior capsule, making sure it is not a posterior polar cataract. In cases, if I like to do divide and conquer, or the surgeon who are doing divide and conquer, my advice is to split the nucleus at the lower part of the nucleus, at the lower part of the groove, like that, to avoid any fracture to the sides of the grooves. But for me, I'm using it chopping all of the time. First, removing the superficial cortex, if there is superficial cortex in my hard cataract, then to put the tuber at the equator, as you are going to see now. This is the tuber at the equator under the anterior capsule, holding the nucleus to be able to fashion the groove very easily, then to divide the nucleus. The groove will be very fast because I'm holding the nucleus so that every pulse or every ultrasound coming from the tip will be efficient. Then rotation of the nucleus and doing the groove at the other side and fracturing the nucleus in the same way. Then starting my shop. Sorry. No way to manage the video. I will speed up the video a little bit. Then, yes, splitting, then engaging the nucleus, rotation of the tuber around the equator of the nucleus to get a very small fragments of the nucleus every time. This is the main key for success and the main key in hard cataract to avoid any trauma to the endothelium, as we are going to see after a while. Dividing the nucleus into small splits and small particles. This will facilitate emulsification of the nucleus. And Of course, everyone will think that this is a very difficult technique, but if you trained yourself to put the tuber under the equator, in the equator of the nucleus, and to start to shop in a small particles like that, the part of the emulsification of the nucleus will be much more and more easier than engaging a large part of the nucleus. Can you shift to the second video? Yes. What about the nucleus emulsification? In nucleus emulsification, it is something different. I have to tailor my fluidics to avoid any post-occlusion surge. As we all know, surge is the part of the surgery that we all are afraid about. If we have surge, we will have opening of the posterior capsule. So that I have to put my fluidics inside the surgery, the inflow equals the outflow. Outflow, we all know that outflow is aspiration and leakage, so that I have to put the inflow equal the outflow during the surgery to have a flat and very cool and smooth surgery during emulsification of the quadrants. As we see here in this video, after division of the nucleus to many particles, I have to emulsify these quadrants. And of course, all machines has post-occlusion mode. In post-occlusion mode and during the occlusion, I have not to reach the occlusion, the maximum occlusion in emulsification to avoid the post-occlusion surge. If I avoided the post-occlusion surge, so that I can go deeper and deeper into the back to be able to emulsify this cataract and very hard cataract. Sometimes I have a continuity between the lower part of the nucleus, so that I have to address this first. If I cannot elevate this part, so that I go outside and I inject OVDs under the nucleus at this connection. By elevating of this connection upward into the anterior chamber, then I'm addressing this connection first. After that, the aspiration of the quadrants will be much more easier. As you see here, after division and splitting all the quadrants, all the pieces from each other, at this moment I can aspirate. Usually, as you see, there is no turbulence inside the anterior chamber. The tip does not occlude too much, and there is no post-occlusion surge because there is no long time of occlusion. But what we are doing, and what most of us is doing, is they are doing this. They are dividing the nucleus into 4 parts, so that they will be forced to go into the anterior chamber with this large particle, and at this moment you will be very close to the endothelium, because ultrasound will not work efficiently inside the bag if you have a very large piece of the nucleus, so that you will be forced to go into the cornea very close to the endothelium, and like this you will affecting the endothelium, and you will have first day corneal edema, and some cases are compromised because we are not doing specular count for the endothelium routinely preoperative, so that most of us in hard cataract will have a severe corneal edema in the first day postoperative, especially if they are not meticulous in the OVDs they are using. They will have this effect over the endothelium. So what we are doing, we have to work inside the bag. If we are dividing the nucleus into multiple pieces, so that at this moment you don't need to go outside the bag to the anterior chamber. At this moment you can emulsify inside the bag. This is again a hard mass of the nucleus. The surgeon will go into the anterior chamber doing too much fraction into the endothelium. This is not clear from the front view. You have to see the side view to be able to judge where is the surgery and where you are doing your phaco. But if we are dividing the nucleus into smaller masses like here, the small mass you will not do occlusion for too long time. By not doing occlusion for a long time, at this moment you will not have that aggressive post-occlusion surge, and if you are manipulating the fluidics a little bit, you will not have post-occlusion surge at all, because I don't have occlusion at all, or the maximum occlusion, by dividing the nucleus into smaller and smaller pieces, as you see. Then after that, I'm shifting, I'm putting my tip bevel downward, facing the posterior capsule, and keeping the tip inside the bag to emulsify the whole of the quadrants, as we are going to see now in the second shot of the video. Can we speed it? Can we move forward? No. Thank you. Go back, please. Yes, can we advance the video? Okay, just a minute, just leave the cursor for me, please. Yes. Now I'm putting the tip bevel downward and aspirating the whole of the nuclear material inside the bag. This is not clear from the front view, but if I shift to the side view, you'll see that the tip is inside the bag. Everything is aspirated inside the bag and emulsified. And keep in mind that everything is stable inside the cheat chamber. I don't have too much turbulence, because turbulence is source of corneal edema and source of rupture of the posterior capsule. This is the distance between the cornea and the emulsified nucleus. The tip is facing into the posterior capsule, just 30 seconds, is facing into the posterior capsule. Aspiration of the small particles is easier than large particles. Large particles will move into the incision, so that you will have to retract the tip backward. At this moment, you will be much more closer to the endothelium, affecting the endothelium, and ends up with corneal edema first day post-operative. But with this cocktail of adjustment of fluidics and ultrasound and inflow and outflow, at this moment you can emulsify inside the bag without any danger over the posterior capsule or the endothelium, as you see, because I'm too much away from the endothelium. Finally, thank you for your attention.
Thank you very much for the fantastic videos. Now it's my talk. So issues when the vitreous meets aqueous. First of all, we have to understand that vitreous cannot be emulsified. Second, vitreous cannot be aspirated. Third, vitreous cannot be seen. It's transparent, so you have to stain it. And traction of the vitreous causes retinal break and, of course, retinal detachment. So there are 4 main strategies we have to just keep in mind. First of all, once there is a posterior capsule and there is, first of all, reduce the bottle height. Number 2, dry vitrectomy. You can do the dry vitrectomy, dry aspiration, if you are dealing with cortex only. You can do it from the anterior and posterior segment when the anterior and posterior segments are connected together. And try to compartmentalize, divide between the anterior and posterior segment of the eye by IOL scaffold, and then you can deal what's going on after this. If you have small nuclear pieces, you can do small slow motion phacoemulsification. If you have some epinuclear fragments, you can do a low cutting anterior vitrectomy, or you have just remnants of the cortex, you can do irrigation aspiration. And again, before conclusion of the surgery, please stain to make sure that there is no any vitreous prolapsed before conclusion of the surgery. So, vitrectomy rules, first of all, should be done through a closed system, maybe limbal or pars plana approach. Settings, you have to be aware of the vitrectomy settings. Start with irrigation, cut, aspiration, and use the highest cutting rate possible with the machine. You can reduce the cutting rate if you are dealing with the epinucleus. You can start with irrigation, cut with a slow cutting rate, and aspiration. And you can switch to irrigation, aspiration, cut for cortex. So key of success, number 1 is early recognition. You have to recognize. You have to have a high index of suspicions. Once you have a sudden deepening of the anterior chamber like this, you have to suspect there is something wrong. You may have a vitreous prolapse inside the anterior chamber. This is the slow motion video. Or you can see that there is a disturbed phagodynamics, that the nuclear fragments is not coming toward the phacopiece as usual. There is something intervening between the phacotip and the nuclear fragments. So first reaction is freeze. Don't move, please, don't move, like this. Once there is a rupture of the posterior capsule, as you can see here, please don't move. Freeze, and keep your foot pedal on foot pedal number 1 on irrigation, and try to inject OVDs. Don't pull out the phaco handpiece from the anterior chamber. Just try to inject OVDs and never allow the anterior chamber to collapse, otherwise it will invite more vitreous. Now switch the irrigation completely, and then now inject viscoelastic, preferably to be dispersive viscoelastic like viscoat or methylcellulose, and then you can pull out the phaco handpiece, and then you can deal with the situation. If you have just only cortex, you are lucky enough, you have finished with the nucleus and you have just only cortex, so you can just do and now you have a connection between the anterior and posterior segment of the eye. Doing vitrectomy, regular vitrectomy may induce turbulence inside the anterior and posterior segments of the eye, which will invite more vitreous because of the hydration. So I prefer in this situation to do the dry vitrectomy, dry aspiration. You can keep the irrigation outside, fill the eye with viscoelastic, do dry vitrectomy, and then dry aspiration for the cortex and intervening again until you are finishing, and then you can do the bimanual anterior vitrectomy to clear any remnants of the vitreous inside the anterior segment of the eye before implantation of the lens. If you have just epinucleus here, you can see that this is phacoemulsification, and almost we are about to finish, and I have noticed that there's a break in the posterior capsule. Here, there's a small break here. Small, it's not very well seen, but it's a small break. So again, freeze, don't move, don't switch off the machine. And now, this is the irrigation on, so this is a mistake. You have to switch off the irrigation once you are injecting the viscoelastic. Otherwise, the viscoelastic will come out from the side port. So inject the viscoelastic, you can inject more viscoelastic, and now deal with the situation. So if there is an epinucleus, I can deal it with phacoemulsification, or I can do vitrectomy. Vitrectomy cannot be seen, so please stain the vitreous with diluted triamcinolone acetate. You can see that mostly the vitreous is coming out through the vicinity of the main wound, or sometimes from the side port. Do dry anterior vitrectomy just to clear the vitreous and the main wound, and you can do again try dry vitrectomy. You can see that the irrigation is outside the eye, and this is only dry vitrectomy to clear the vitreous at the main wound and the side port. And now try to compartmentalize, divide between the anterior segment and posterior segment of the eye by the IOL scaffold technique published by Amar Agrawal from India. And now, this is the three-piece lens. You can implant the regular three-piece lens. Any three-piece lens, you can just implant it inside the anterior chamber. Inside the anterior chamber. Keep the haptics above the iris, and now deal with the situation. If you have a nuclear fragments or epinucleus. Epinucleus in this, like this situation, you can do just vitrectomy. And you have to be aware with the vitrectomy settings. Of course, vitrectomy should be done through a very closed system. So I have to create another side port for the irrigation and the side port for the vitrectomy cutter. And now you can see that the vitrectomy rate, the cutter rate, is very low because it gives time for the epinuclear pieces to be molded inside the shaft of the vitrector and to be cut and aspirated. So reduce the vitrectomy cutter, and then you can now complete the and do bimanual irrigation vitrectomy, and then this is the lens. Now you can just implant the lens in the sulcus if you have enough capsular support, or you can do the Yamani technique like this. In this case, if you don't have the support, enough support. Let's move this one. This is here, the Yamani technique. And please, please, again, stain just before conclusion of the surgery, because sometimes vitreous might have prolapsed while implanting the lens. This is another case. Again, epinucleus, low cutting rate. Try to deal with the epinucleus as with a low cutting rate of the vitrector, and then you can give some time that this low cutting rate will aspirate and smash the epinucleus into the shaft of the vitrector. You can do it through a limbal approach, or you can do it through pars plana approach. Sorry. Again, this is pars plana approach. I prefer in some situation pars plana approach because it does not invite more vitreous. If you are doing limbal approach, it may invite more vitreous from the posterior segment of the eye. So I prefer, in most of the cases, to do the pars plana approach, so just to get the vitreous back again from the anterior segment of the eye to the posterior segment of the eye, and try as much as you can to preserve your anterior capsule and posterior capsule. In this situation in particular, you can see after doing a proper vitrectomy that we have a very good remnant of the posterior capsule, so we can implant the single piece lens inside the capsular bag. You can see here, this is a multifocal lens, and as you know that the multifocal lens is present only in single pieces, so I have no way except to implant the lens inside the anterior, in the capsular bag. So preserving the posterior capsule is an issue here, and one of the tools to help you to preserve the posterior capsule is do the pars plana vitrectomy. If you have a nuclear fragments, again, this is, you can do the scaffold technique. This is anterior vitrectomy, then you can do the scaffold technique. Again, keep the lens inside the anterior chamber. If you are not sure about the trailing haptic that might fall down in the posterior segment, just keep the trailing haptic outside the eye, like this one. Keep the trailing haptic outside the eye, and then you can deal with the nuclear fragments with phacoemulsification. You can do just a very slow motion phaco. Don't forget to reduce the bottle height before starting again phaco, and you may reduce the vacuum, and of course you have to reduce the aspiration rate. Try to do slow motion phaco. Fill the anterior chamber with ample amount of viscoelastic because to protect the corneal endothelium, because you are working very close to the corneal endothelium. Then, if you have a remnants of the cortex, you can do now the anterior vitrectomy. You can see here a pars plana anterior vitrectomy, and again, this is irrigation, aspiration, cut. Now, it's irrigation, aspiration, and for the cortex, and once the vitreous is coming, intervening between the cortex and the vitrector, you can switch the cutting rate by pressing the foot pedal to position number 3. And again to position number 2 if you are dealing with just cortex, and if there is any vitreous, again, you can switch to position number 3 for the activating the cutting rate. So you have to be aware about the vitrector settings here. This is irrigation, aspiration, cut. Irrigation, aspiration as usual, and cutting when it's needed. And once you are finishing with this cortex, you can now place the lens in the haptic with doing the optic capture, as you can see here. And again, just before conclusion of the surgery, please, please, please stain to make sure that there is no vitreous has been prolapsed inside the anterior chamber, and most probably toward the phaco wound. And if you are lucky enough that you don't have vitreous inside the anterior chamber, now this is during the last pieces of phacoemulsification, there is a small hole here in the posterior capsule here. This is posterior capsule, a small hole here. So again, stop, freeze. This is the rule. Reduce the bottle height, of course, and now inject OVDs. And because there is no vitreous here, you can start phacoemulsification right away after implanting the lens to compartmentalize, to divide between the anterior and posterior segment of the eye. And because there is no vitreous, there is no need for vitrectomy so far. So just do the slow motion phacoemulsification and then place the lens from the anterior chamber to the sulcus or the bag if you have enough capsular support. And again, please, before conclusion, stain to make sure there is no vitreous. So my key messages is just 5 words. Freeze once recognized, reduce bottle height before dealing with the vitreous in the anterior chamber, dry vitrectomy if you have connection between the anterior and posterior segments, compartmentalize the segments by placing the IOL in the anterior chamber, 3-piece IOL, to divide between the anterior and posterior segments of the eye. And please don't forget to stain the vitreous with triamcinolone acetate, diluted triamcinolone acetate before conclusion of the surgery. Thank you for your attention. Now we'll start with the discussion. So any question from the floor to Dr. Rakesh from India? We'll start the first presentation, please. Any question to Dr. Rakesh? His presentation about the errant capsulorhexis. So any questions about the errant capsulorhexis, please? So I suppose that most of the audience can do very good capsulorhexis. Okay, I have a question to you. You showed beautifully how to deal with Argentinian flag sign. And could you please advise us about the settings of the machine in order not to allow the extension, the tear to extend through the equator to the posterior segment of the eye? Because you dealt with you did capsulorhexis on either side, okay? And then you did phacoemulsification, and you have very stable anterior chamber. I think the key here is to have a very stable anterior chamber during phacoemulsification. So could you talk about the settings of the machine during such situation, because this is mandatory?
Actually, in that case, is actually the nucleus was very soft. First thing is that, and that we keep the parameter or parameter very low. Like the vacuum should be like the 200, 250, and the flow rate is the 20, 28, and it should be give the very stable chamber. And second thing is that you can prolapse the nucleus to anteriorly over the capsule. So by this reason, you can do the supracapsular phacoemulsification is better to do during when the Argentine flag sign you can notice. So this is the key factor, I think.
So about the little technique you showed beautifully, can you stress about I think you should refill the anterior chamber with viscoelastic just before doing this maneuver, right or not?
Yeah.
Okay, so what kind of viscoelastic do you usually use in this situation?
And actually just you fix the further extension. So first you actually put the high molecular weight viscoelastics mainly, and then over it, and you can use the in between the dispersive also. Both viscoelastic can be used actually.
Any viscoelastic?
Yeah.
Okay, thank you very much. Okay, any question? Yes, please.
Dr. Ahmed, unfortunately, we have to move to the next session. Yes.
Okay, but we have already 5 minutes. We delayed 5 minutes in the very beginning, but anyhow, it's okay. Yes. We have to conclude this session. Thank you very much for your attention.
Thank you very much.